Thanks so much, Dr. Dale Haas, for the invitation to speak today about a topic that I've been interested in for quite a while. So let's get started. I have no disclosures related to this presentation. And our objectives are to, praise some of the established associations between this restrictive spirometry pattern, symptoms, and quality of life. Describe some of the cardiovascular and metabolic consequences of low lung function, particularly low vital capacity, and to assess, whether there's ways to potentially prevent or ameliorate low lung function and restrictive spirometry. So I'll start with the case. A typical kind of PFT. You get a limited amount of clinical information. So we have a 55-year-old male, 10-pack year former smoker. Says the reason for the spirometry was screening, not uncommon. By any kind of criteria, his FEV1 to FVC ratio appears to be normal. He's not obstructed. His FEV1 is 71% of predicted, though. And his FVC is 71% of predicted as well. You look at the PFT report, his BMI is 28 kilograms per meter squared. He has a pretty good looking flow volume loop. So how should we interpret this spirometry? Is this patient likely to be symptomatic or functionally limited by his reduced FEV1 and FVC? And, what's this patient's prognosis? So my fellows drive me crazy when they read this as normal. So hopefully we could recognize this isn't normal spirometry. The ERS ATS technical standards gives a nice table or chart of how to interpret spirometry when the FEV1 and FVC are reduced, but the ratio is normal. So they mention restrictive impairments, first of all, but comment that you need really lung volume testing and a reduced total lung capacity to confirm this. You could read this as a non-specific pattern, but in that case, you'd have to, again, know that the total lung capacity was, in fact, normal. And then they offer the possibility of preserved ratio impaired spirometry, and they note the FEV1 would be low, the FVC would be low, and I put an asterisk there because that's actually not part of the definition of PRISM. And the ratio would be normal, and you could use this when the TLC is not available. And they also comment that you should use this in current and former smokers. So we could apply this label, potentially to the case that we're talking about. We can eliminate muscle weakness or suboptimal effort based on the flow volume loop, which had a nice sharp peak expiratory flow. So what about what we're talking about today, restrictive spirometry pattern? It shows up in a lot of epidemiologic studies. It's a term that's been used to describe an abnormal pattern on spirometry where there's no airflow obstruction, but there's subnormal lung function, particularly a low forced vital capacity. Various definitions are applied in different studies. Probably the most common is what I'll call the fixed ratio definition. It sort of takes that 0.70 cutoff that the gold criteria used to define airflow obstruction and says if your ratio is greater than or equal to 0.7 and your FVC is less than 80%, then you're in this restrictive spirometry pattern grouping. Other studies have used lower limit of normal to define the ratio and FVC, and some use a hybrid. Preserved ratio impaired spirometry or PRISM is generally defined as a preserved FEV1 to FVC ratio by either the gold cutoff or the lower limit of normal, and then a subnormal FEV1. In fact, low FVC is not required. And maybe if we have time at the end, we could show that though you'd think these two patterns would overlap, maybe the overlap is not as complete as you'd expect. So how common is this? Well, our best estimates for the prevalence of restrictive spirometry, at least in the United States, would come from the NHANES studies, which are designed to be nationally representative samples. And the prevalence in the US and the general population that's recruited for NHANES is about 7% of the overall population. So maybe half as much as the prevalence of airflow obstruction. But if you think about 7% of the US population having this abnormality, that's a lot of people. Other large population studies in the US, like the atherosclerosis risk in communities study, the Mesa lung study, Jackson heart study, have shown somewhat higher prevalences, especially in Jackson heart. To take an example from Europe, and there's many other examples it could have chosen, but this one from Sweden, the prevalence in this study was about 5%. So generally comparable to the US if you look at European populations, somewhere in the mid to upper single digits. This is a more recent example, very large study from South Korea, where the prevalence of restrictive spirometry in this population was 19% using that fixed ratio definition, and much lower using the lower limit of normal. The burden of obstructive lung disease study actually attempted to look at the sort of worldwide, quote unquote, burden of restrictive spirometry. This study used collected spirometry data from 22 sites worldwide. In this publication, they defined restriction as just a post-bronchodilator FVC that was less than the lower limit of normal. And they used the NHANES 3 spirometry equations to define this, particularly the equation for Caucasians as their reference. And they found the prevalence of restriction vary quite widely among the different sites worldwide and between men and women as well. They saw some of the lowest rates in Europe in the 6 to 8% range, but in India, almost 70% of men and a little over 70% of women met this definition for restrictive spirometry. One of the interesting things they found was that when they looked at COPD mortality rates in each of the nations that they conducted the study in, they found that national COPD mortality correlated much better with the local prevalence of restrictive spirometry, just low FVC, than with airflow obstruction. Actually didn't correlate at all with the prevalence of airflow obstruction. And the correlation was quite high, especially in middle-aged men and women. So to summarize some of that data, restrictive spirometry is quite common in populations worldwide. We can say with some confidence, based on the definitions used, it will be present in about 7% of the US population. But there's really a variation on prevalence depending on the group that you study, the reference equations used, or the definition used, but it's always there. At some, fairly significant level. So when does this develop? Is this something, people essentially have from childhood? Is it something that comes along as adults? What causes it? What are the consequences? The third question is probably the easiest and one with the most data. I'll try to tackle some information on the first two questions to begin with, though. So there's been several studies published in the last 3 years looking at risk factors for restrictive spirometry. So this is one that was published in Lancet Respiratory Medicine in 2022 by Vorafani and colleagues. And they assessed early life risk factors for having restrictive spirometry in adulthood. What they did is they used data from the Tucson Children's Respiratory Study. This study enrolled 652 infants who went on to have spirometry in young adulthood. When they did have their spirometry in adulthood, they defined restrictive spirometry by yet another definition using percentiles and FVC less than the 10th percentile, and this was about 10% of their cohort. They then tested the risk factors that they uncovered in two other cohorts, one from Sweden and one from the UK. What they found in the infants who were enrolled in Tucson and later developed adult restrictive spirometry, the early life risk factors that they uncovered were maternal nutrition problems in pregnancy, particularly hyperemesis and anemia, being born small for gestational age, conferred about 3 times the risk of subsequently having restrictive spirometry, and childhood underweight, having a low BMI between the ages of 6 and 16, also tripled the risk of subsequently having restrictive spirometry as a young adult. Being small for gestational age and being underweight in childhood were consistent risk factors in all 3 cohorts. The other 2 couldn't really address the maternal nutrition problems because they didn't have that data. One study looked at body composition and found that the role of underweight, the increased risk that was conferred, really associated with having a decreased lean body mass rather than a decreased fat mass. And interestingly, although we see a lot of obesity with the restrictive spirometry in adults, obesity and underweight in childhood was not a risk factor for developing restriction. The second study that looked at risk factors for developing this spirometry pattern was published last year in Thorax by Carson and colleagues. They took data from the European Community Respiratory Health Survey. This was a pretty large study that recruited people from the general population in Europe and also, despite the name, in Australia. And then they enriched the cohort for persons with asthma. What these authors did is they took people who are young adults between the ages of 20 and 39 at the time of the initiation of the study. And these young adults all had spirometry at that time, and about 11% of them had a restrictive spirometry pattern. Those young adults who had normal spirometry at the first study visit, they followed up 20 years later when they were now in mid-adulthood and had another round of spirometry and found an additional 5% of the overall cohort had developed a restrictive spirometry pattern in mid-adulthood. And they asked what factors were associated with the onset of restriction in young versus mid-adulthood. So interestingly, the one thing they found was the trajectories of FVC decline with age were different in these groups. So those who had the young onset restrictive pattern, by definition, had a low FVC from a young age and actually tended to lose their vital capacity with age a bit slower than the other groups. Those who had onset of restriction in mid-adulthood had the steepest trajectory for FVC decline with age. And those who are normal or who had airflow obstruction on spirometry all tended to have sort of the same trajectory in terms of FVC decline with age. So there was something different about those in mid-adulthood that was causing them to lose lung function somewhat more steeply over time. So the risk factors they found for restrictive spirometry in young adulthood was having a history of childhood respiratory infections, having a low BMI, again, being underweight at the time of the first study visit, or being obese. So the extremes of BMI at the time of the first study visit. Recalling having a lean body silhouette at the age of 8. They showed them different cards with body, silhouettes and asked them to point to the one that most resembled how they looked at that age. And then having asthma symptoms within the last 12 months. By contrast, those who are restricted in mid-adulthood, these factors all seem to relate again to high BMI, having an obese BMI, in young adulthood, reporting a large body silhouette at age 30. And this group had the largest BMI change over that 20-year period. Their BMIs increased about 5 kilos per meter squared on average. The final study I'll talk about in terms of risk factors was published in Lancet Respiratory Medicine in 2023 by Dartmouth and colleagues. This is one of the more interesting studies, I think. They took data from the Tasmanian Longitudinal Health Study. Very interesting. This study recruited almost every child who was born on the island of Tasmania in Australia in 1961. And they measured spirometry in this group during childhood and then again during middle age. They measured lung volumes and diffusion capacity when they were middle-aged as well. And they used this data for those who were in the study from the time of childhood till the age of 53 to define different spirometry categories according to their FVC and FEV1 over FVC trajectories over time. Now, they found quite a few trajectories. That's pretty complicated. Fortunately, we can only have to focus on the one low FVC trajectory and then the three trajectories that resulted in a normal or high FEV1 to FVC ratio defined the restrictive only group outlined there in red. And that was about 10% of the overall cohort had this restrictive only pattern versus an obstructive only pattern, a mixed pattern with a low FVC and a low FEV1 FVC ratio, and then a normal spirometry pattern. So the childhood factors that they associated with developing this restrictive pattern was one being male. That was more common to be male to have restriction. Having, again, more likely to have a history of childhood respiratory infections, including bronchitis or pneumonia. And again, being underweight in childhood. So that was more than twice as common in the restrictive group as in the reference group. Again, there was no association with being overweight during childhood, actually no relationship with parental smoking, with how they were fed as infants. And in this study, they did not see an association with being small for gestational age. When they measured this group's lung volumes and diffusion capacity at the age of 45, this restrictive-only spirometry group indeed had lower total lung capacities than the reference group, about a standard deviation lower. They had lower functional residual capacities than the reference group or the obstruction group. And although they had lower diffusion capacities, their KCO, or their diffusion capacity divided by the alveolar volume, was in fact higher than all the other groups. And when we see this pattern of low total lung capacity and high KCO, we tend to think of an extra parenchymal, extra outside of the lungs reason for their restrictive abnormality. So how were these children who had developed restriction doing at the age of 53? The answer is not very well. They were much more likely to report symptoms like dyspnea, sputum, and wheezing. They were more than almost 3 times as likely to have active asthma symptoms and to use inhaled medications for their symptoms. Although underweight was more common when they were children, this group was now more likely to be obese. And they seem to have higher levels of inflammation. Their C-reactive protein levels were about twice as high as in the normal spirometry group. And they also had a lot of baggage in terms of comorbidities. They were more likely to have hypertension, diabetes, and sleep apnea in midlife. There was no association, however, with COPD, with whether or not they smoked, or with their socioeconomic status, either in childhood or in adulthood. So to summarize this, some potential risk factors that I think these studies have highlighted. One is the relationship with low BMI and being underweight in childhood. That seems to be a very consistent finding. The other that's quite consistent is the relationship to childhood respiratory infections. Being small for gestational age was seen in several cohorts. This question of, relationship with maternal nutrition problems in pregnancy is a bit less clear. And then again, as we see in adults with restrictive spirometry, there's often association with high BMI or with BMI gains. But I think this is a question of, is this a cause of restrictive spirometry or is it a consequence of having low lung function? So does low lung function have some relationship with metabolism that leads to obesity and weight gain is a question. So why so much attention to this abnormality on, spirometry testing? Why does it matter? Well, I think it matters for several reasons. I mean, one, this is something that's quite prevalent in the population, so we need to understand it. But two, individuals with restrictive spirometry, as the last study from Tasmania illustrated, tend to have a lot of symptomatology. So this group is much more likely to report having either fair or poor health as opposed to good health status. They're 2.5 times more likely to report functional limitations. And these are pretty basic things like being unable to walk a 1/4 mile or to lift 10 pounds. They're 9 times more likely to need help with their daily activities. A segment of this group is going to be pretty impaired, need assistance. And consistently, this group reports worse respiratory symptoms and higher dyspnea scores than people with normal spirometry. And they're also more likely to have had basically a COPD exacerbation, even though they don't have COPD. Just to illustrate one example of this from the COPD gene study, this was published by Vaz Fregoso about 10 years ago. And about 10% of the COPD gene cohort, which consisted of current and former smokers, so not sort of representative of the non-smoking population, but about 10% of this cohort had restrictive spirometry when classified. And those with restrictive spirometry had very comparable shortness of breath scores to those with moderate COPD. They had about a 10-meter lower 6-minute walk distance on average than the moderate COPD group, and over 30 meters less than the normal spirometry group. And their St. George's Respiratory Quotient questionnaires, which is a quality of life questionnaire where a higher score means a worse quality of life, again, was quite comparable to that of the moderate COPD group. And just to put this 6-minute walk distance in perspective, we were doing a journal club with our fellows yesterday, talking about an article on IPF, and I noticed the IPF group had an average 6-minute walk distance of 390 meters in that study. So this, suggests some impairment here. There's interesting relationships in some studies between low lung function and cognitive function, which is also interesting. So in this study from England, having a lower FVC percent was associated with basically lower IQ scores at ages 8 and 15. At the other end of the age spectrum, restrictive spirometry in the elderly is associated with higher odds of cognitive impairment, lower mini mental status scores, and impairment in cognitive IADLs. And, certainly this doesn't mean that low lung function causes cognitive impairment. I think you'd have to question the direction of that association, but those associations have been but I think the real reason, people have paid so much attention to restrictive spirometry is its pretty robust association with premature mortality. And I'll try to go through some of that data now. So in the 1970s and 1980s, studies, such as the Framingham Heart Study, related spirometry measures with mortality, and this included both FEV1 and FVC. These studies often lacked adjustment for factors related to lung function or mortality that, contemporary studies would probably adjust for. So it's a little, hard to interpret the data at the current time. But that interest in a connection between lung function and mortality, which has been present since I think the spirometer was invented, has persisted. So to give an example, Bernie and Hooper in 2011 reported a higher FVC was associated with a lower mortality risk in asymptomatic individuals that were enrolled in the ERIC study. And this association between FVC and survival persisted after adjustment for the FEV1. And in fact, the other way around, it did not. So although a higher FEV1 was associated with lower mortality risk as well, once you adjusted for the FVC, that relationship was no longer significant. And they found no association between the FEV1 FVC ratio with survival, and kind of provocatively suggested, maybe this focus on survival and spirometry was more related to restrictive rather than obstructive spirometry, which had always been the assumption that, low airflow obstruction leads to premature mortality. So we know that that's probably not true. Both airflow obstruction and restrictive spirometry are bad things to have from the standpoint of survival. This is data from the TESSEAD study in Tucson, where they measured participants' spirometry at multiple time points, followed them over time. I think it's a nice illustration. Those who had consistently normal spirometry had the best survival over the 30 years plus of the study. Those who had consistent airflow obstruction had the worst survival. And you could see those who had recurrent or inconsistent, meaning from spirometry to spirometry, not necessarily always meeting the restrictive criteria, had significantly worse survival than those with consistently normal spirometry. So they were closer to the airflow obstruction group, but maybe not quite as bad off. In this association between restrictive spirometry and low FVC has been, I think, confirmed time and again in a number of studies. Here's a more contemporary illustration. This is data from the pneumoconiosis survey of Western Norway. This study recruited over 26,000 Norwegian men in the late 1980s, performed spirometry at that time, followed that group for 26 years, and looked at cause-specific mortality in 2016. Both a lower FVC and having the restrictive spirometry pattern were both associated with an increased risk of all-cause mortality. When they looked at the cause-specific mortality, one of the things that really stood out was a very high in magnitude association with diabetes-related mortality in both of these groups. But also respiratory and various forms of either cardiovascular or cerebrovascular mortality risk. And these are just a handful of examples. There's many studies that have related restrictive spirometry to premature mortality, to all-cause mortality. And I think you could see that this is just to illustrate there's consistently a significant relationship between the two, whether you're looking at groups of people in Sweden and in Taiwan, in the US, elsewhere in Europe or the US. That relationship with all-cause mortality is quite robust. In the studies that have looked at diabetes-related mortality, that does seem to stand out in terms of the magnitude of that risk. And then another fairly consistent finding in most studies is a relationship with cardiovascular related mortality. So just to turn to that connection with cardiovascular disease next, restrictive spirometry, when you look at that group of adults who fall into this category, they tend to have a higher burden of comorbidities like hypertension and diabetes, and they tend to have a higher prevalence of pre-existing cardiovascular disease. So again, that raises the question of the direction of that association. Does the cardiovascular disease impair their lung function and cause them to have restrictive spirometry, or vice versa? What I think is clear now is it's you probably go from low lung function to having increased cardiovascular risk. This was an early study published by Menino and colleagues showing that relationship between the risk of a new or recurrent cardiovascular event in those with restrictive spirometry. And again, it was roughly comparable to the risk conferred by having, gold grade 2, moderate COPD in terms of the risk of a cardiovascular event. We were interested in the connection between spirometry patterns and the risk of heart failure. So certainly, if you have heart failure, that can impair your lung function. So we wanted to look at people who are free of heart failure and look at incident heart failure or hospitalization. Subsequently, we did this in the Jackson Heart Study in over 4,000 participants in that study who were free from heart failure at the onset and had spirometry. This was a middle-aged group, 55 years old on average. 20% had a restrictive spirometry pattern, and about 8% had airflow obstruction, and the remainder had normal spirometry. These participants had echocardiograms done at the same study visit as their spirometry, and they had higher, on echo, those with restrictive spirometry had higher mitral E wave velocities, E to A ratios, and pulmonary artery systolic pressures, suggesting, maybe some subclinical diastolic dysfunction. They also had higher serum endothelin-1 levels, which is a pretty potent vasoconstrictor. In follow-up, over the course of 8 years, 8% of those with the restrictive spirometry pattern were hospitalized for new heart failure. That was more than double the percentage in the normal spirometry group and a bit less than the percentage in the airflow obstruction group, as illustrated in the chart on the right. So after adjusting for risk factors, there was a 50% increased risk of heart failure hospitalization with the restrictive spirometry. And when we looked at this risk of heart failure as a function of the forced vital capacity, what was interesting is the hazard of heart failure was really lowest around a FVC of 90 to 100%, and then started to go up from there. And, especially started to increase below an FVC of around 70%. And that risk was sort of nonlinear. It really increased dramatically the lower the FVC went. Having a low FVC was also associated with having a higher pulmonary artery systolic pressure and higher levels of endothelin. We went on to look at the relationship between spirometry patterns and left ventricular and aortic structure and function. In the subgroup in the Jackson Heart study, who went on to have cardiac MRIs, and we recently published this data. Those who had airflow obstruction were more likely to have an elevated aortic pulse wave velocity, which is a measure of the stiffness of the aorta, and is a bona fide risk factor for cardiovascular disease. Whereas those who had either the prism pattern or restrictive spirometry were more likely to have a decreased left ventricular stroke volume, which is interesting and novel association, and does suggest this could be part of the pathogenesis of potentially heart failure in this population. The last study I'd like to talk about that was just recently published by Surya Bhatt and colleagues in the Annals of the ATS was a study relating lung function and risk of coronary heart disease. His group pooled the lung function and clinical data from 8 large U.S. general population cohorts. What was interesting is they defined impaired lung function as a forced vital capacity less than or equal to 95%. So well within the range of what we would consider quote unquote normal. But in fact, this was lower than, sort of the average for the populations enrolled in these studies. They looked at the relationship of this low lung function to coronary heart disease mortality and went on to calculate what's called the population attributable fraction of low lung function for CHD mortality. So there were 35,000 participants in this pooled cohort. 43% of them had a FVC less than or equal to 95%, and that was the low FVC group. Restrictive spirometry was present in 7.3%. Over 20 years of follow-up, there were over 1,800 coronary heart disease deaths, and indeed, as you might expect, from prior studies, low forced vital capacity or having the restrictive spirometry pattern did indeed increase the risk of coronary heart disease death after adjustment for other risk factors. What was interesting is to put this in perspective, looking at the attributable fraction of the population with coronary heart disease mortality in terms of how common the risk factor is and how much it contributes to coronary heart disease mortality burden. Well, hypertension is the most common risk factor. It accounts for about 33% of coronary heart disease death. Diabetes, about 16%. But having an FVC less than or equal to 95% accounted for 13% of the coronary heart disease mortality in this study. So that was ahead of smoking at 11%, high LDL cholesterol at 6%, and obesity, which really wasn't significantly associated with coronary heart disease mortality, but maybe through the other risk factors certainly may relate. So that was a pretty provocative finding and suggests we should be paying, more attention to what causes low lung function and how to potentially manage that. The other connection that's consistently seen with restrictive spirometry is the association with metabolic disease, particularly diabetes. So diabetes is frequently more prevalent in adult individuals with restrictive spirometry. For a while, this was thought to be effects of diabetes on lung function, which may exist. But then a number of studies showed that having low lung function or having restrictive spirometry actually seem to be a risk factor for developing either insulin resistance over time or diabetes over time. So suggesting this relationship could be, bidirectional. My friend Chao-Fu Kei at Soochow University in China looked at this recently in terms of the risk of developing one or more cardiometabolic diseases, including type 2 diabetes, using data from the UK Biobank, a very large prospective study in the UK based on baseline forced vital capacity. And again, what he found that was quite interesting, over 10,000 individuals developed type 2 diabetes in the follow-up period that he studied. The correlation between FVC and the risk of developing type 2 diabetes was interesting. The lowest risk was at really good FVCs, 110 to 120% of predicted. And then the risk began to climb and really crossed unity around the FVC of 99% of predicted, a little less than 99% of predicted. So you can see, even if you had a FVC of 90% of predicted, you had an increased risk of developing diabetes compared to, say, someone with a FVC of 100% of predicted. And that risk really climbs pretty remarkably, even again at levels of FVC that we would certainly consider normal on a pulmonary function test. What he found as well is that going from a baseline healthy state to a state with more than one cardiometabolic morbidity, that having better FVC was protective against most of these transitions, from healthy to having a stroke, to having coronary heart disease, to having type 2 diabetes, and then most of the subsequent transitions from one of these conditions to multimorbidity, the exception being the transition from type 2 diabetes to multimorbidity. So what can we conclude about morbidity and mortality related to low FVC and restrictive spirometry? Well, I think there's fairly robust associations between low lung function non-airflow obstructed pattern and mortality. There's this especially strong relationship with diabetes-related mortality that I think is really quite interesting. The risks tied to having a low forced vital capacity include type 2 diabetes, heart failure, coronary heart disease, and stroke risk. There's really a narrow range of ideal optimal lung function with measurable risks of some of these outcomes well within the normal range of the FVC. So using lower limit of normal definitions, especially to define what's considered abnormal, we may be missing a really large population that's at risk of adverse outcomes. So we really have to take that into account. So finally, the last few minutes, I'll ask, can we prevent this from happening? Can we prevent low lung function and restrictive spirometry? Because it seems like that would have a lot of benefits, especially down the road in adulthood. So some of the potential risk factors that have been uncovered in the last few years suggest opportunities for intervention. So childhood respiratory infections, if we can prevent those, it doesn't seem like having more infections leaves you stronger in the end. It actually leaves you more vulnerable to low lung function. I didn't have time to go into this, but patients who have had pulmonary tuberculosis, if you look at cohorts of patients, restrictive spirometry seems to be a common outcome of pulmonary TB. So again, preventing and effectively treating pulmonary TB may prevent a lot of this burden worldwide. Childhood underweight, addressing the factors related to that, and then adult weight gain and obesity. It's an interesting question of if we could prevent that or modify the risk of obesity in adulthood. Would that prevent some of this adult onset restrictive spirometry? Physical activity seems to be effective at preventing the development of low lung function. There's been a few studies relating higher levels of physical activity with decreased risk of developing restrictive spirometry. And in this study from Texas, this was regardless of BMI. So if you were obese but had a good fitness level, you had a lower risk of developing restrictive spirometry than people who were normal weight but unfit. The last thing I'd like to address is air quality and its relationship to low lung function development. I think this was very nicely illustrated about 10 years ago in this publication in the New England Journal from a group from Southern California. They looked at lung growth from the age of 11 to the age of 15 in 3 cohorts or waves that were enrolled in the Children's Health Study in Southern California. And they examined lung growth in relation to air pollution measurements that were prevalent in the communities at the time. So for consistency, they studied children who grew up in the same 5 study communities during the 90s, 1997 to 2001, and then from 2007 to 2011. So children who were age 11 at the onset and age 15 at the age of those time periods. They defined lung growth as the change in FEV1 and FVC from the age of 11 to the age of 15. And they also looked at the proportion with low lung function or a FVC less than 80%. What they found is during this time period, many measures of air pollution improved in California due to regulations at the time. So nitrogen dioxide levels decreased dramatically, PM 2.5, small particles in the atmosphere decreased as well, and PM 10 decreased pretty consistently as well. Ozone levels, not so much. They were pretty variable during the time period. In terms of the relationship between air quality and lung growth, they found that children who grew up with lower levels of air pollution as measured by nitrogen dioxide, PM 2.5, PM 10, all had better lung growth. So if you were in a better air quality time period, you tended to have more lung growth than the children who grew up in time periods where there was more pollutants in the air. And in fact, the proportion of children with low lung function also declined in the latter cohort, the 2007 to 2011 cohort, pretty dramatically. So if you look at the kids who had FVC less than 80% of predicted, the risk of that seemed to be cut in half, going from 1994 to 2007. There was no association between improved air quality and increases in height. So this wasn't just the kids were, getting taller and therefore having bigger lungs. It seemed to be, maybe a lung-specific association. Now, it's not a causative, you can't, it's a correlation and not a causation question, but it's certainly biologically plausible that growing up in a, environment with better air quality, you're going to have better lung growth. So I think that's an optimistic way to end this talk. So in conclusion, having a low forced vital capacity and having this restrictive spirometry pattern are quite common in the population. These seem to be bad things to have in that they're associated with increased symptoms, worse quality of life, and then this risk of cardiometabolic consequences and mortality in adulthood. Consistent childhood risk factors for restrictive spirometry include being underweight and having a history of respiratory infections in early childhood in particular. And this steep loss of FVC, this bad trajectory that we saw in, at least one study seems to be what leads to restrictive spirometry in mid-adulthood, and sort of understanding that and potentially how to intervene or prevent that from happening is, I think, an area of interest. Improving air quality, promoting physical activity are things on a societal and individual level that we could potentially do to help prevent development of low lung function. So I'll stop there and I'll say thank you again for this opportunity to speak, and I'd be happy to take any questions.